Welcome to Interface. My name is Thembi Samachele. Well, we've just commemorated World AIDS Day on the 1st of December, as you know. And tonight on Interface, we take stock of some of the wins and challenges that still remain in the fight against HIV and AIDS. The HIV vaccine trials in South Africa have been welcomed with relief in a country which ranks amongst the world's 20 most high-risk countries when it comes to the HIV pandemic. Now, for more, here's a quick look at an insert produced by Rosalia Whitehead.
My name is Makapela, originally from Eastern Cape, deep rural areas of Eastern Cape, and I moved to Johannesburg in 2002 December, and I am a woman who's living with HIV. I'm living openly with my HIV status.
Makapela discovered that she was HIV positive at the cusp of change. In 2005, government began rolling out a massive antiretroviral treatment program through its public health system. But there were problems.
I was sick, and then I was diagnosed with PJP pneumonia, pneumocystis jirovecii pneumonia, which was 2005. After a sickness which took me about 3 months or so, and then I had short breath, and then only to find out after I was admitted that, I was having EPCP, and the lay counselor, encouraged me to test for HIV, and which I still believe that. I tested very late because my CD4 count was 0.8, and my weight was 28, so I was full-blown with AIDS.
She was tested for HIV only after falling sick again and several visits to the Pulisong Hospital in Tsakane, Ekurhuleni. After the initial shock of her daughter's HIV status, Makapela's mother was concerned about where she would access her treatment. The hospital had a long waiting list.
I knew that there were antiretrovirals, that there is a rollout in some of the hospitals, but how am I going to go through? So I went to the doctor. I asked some questions. I asked if she can give us treatment. I didn't know how the treatment is working. I didn't know how many tablets she must get. But the doctor gave us 2 types of tablets. And then we came back and started treatment.
The hospital was overburdened. It had no referral facilities. This meant it had to carry the burden of serving over 7,000 HIV patients.
I was not going to survive if my parents didn't take me to the private sector. So I had to go and get medication, which my parents paid for from the private sector, even before I was switched to the public hospital. If I recall, I think I was referred by the private doctor to public hospital after 5 months or 6 months or so, because I had to wait to get to treatment in the public sector.
Makapela lives with the sad reality that she was forced to disclose her status before she was ready.
I won't say I was ready. I think community, society pushed me to disclose because already people, instead of supporting me, they were gossiping about me, assuming that I'm living with HIV. But I had to come out and say, yes, I have HIV, so what?
The AIDS Legal Network of South Africa says stigma and discrimination remain barriers for people living with HIV who want to disclose. Makapela believes there are underlying factors to deal with before disclosure.
No one should be pushed to disclose her or his HIV status because of the stigma. I think all of us, we are ready to tell our HIV status to our partners, to our family members. But it happens that the society, the community that I'm expected to disclose to is not ready to accept me. So I think sometimes even lay counselors, even government should find tools in terms of how we are going to deal with the stigma in the community so that when we want to disclose, the environment is conducive for us.
South Africa has come a long way. Today, about 10 million South Africans take an HIV test every year. AIDS-related deaths have decreased and life expectancy has begun to rise. Our response to HIV is framed by broad global policy to vigorously provide comprehensive treatment and care to as many people as possible. All these interventions have had a dramatic effect. Rosalia Whitehead, Interface, Johannesburg.
Let's welcome our guest now here on Interface. Yogan Pillay is the Deputy DG at the Department of Health, and we're also joined by Dr. Fatima who is the Director of Hiv Vaccines Research, and they're going to talk to us a little bit more about where we are when it comes to the fight against HIV and AIDS. Thank you very much for joining us. Welcome to the program.
Good evening,
So
Teresa.
we heard the story of Nonyanyambo Makapela there, and she was talking about just how far she's come in her own personal journey. A few years ago, she would have been, a case of sadness where we would have talked about how she didn't make it. But look at today, look at the interventions that are there, and it's a different story. Talk to us, if you will, just as a start, about some of the strides that have been made, Dr. Lehe, in this fight against HIV and AIDS.
HIV has been an extraordinary journey for communities, patients, and healthcare workers alike. In the last 25 years, the medical advances that have happened have allowed people to live longer, people to prevent transmission to others, people to prevent transmission to their own babies, and for people to prevent getting AIDS-related diseases. It's allowed communities to integrate better with people who have HIV. In many ways, we as South Africans are living proof that technological advances, scientific advances, humane advances in healthcare can be implemented, that there can be success in our country and we can lead it. We have not only rolled out treatment for people living with HIV, but we are now leaders worldwide in the fight to prevent people from getting HIV.
We're going to get to the specifics of that in a short while, but Rosalia in the package was talking about how we've made strides, for example, in the testing space. More and more people are getting tested. Where else are we winning?
The other place that we're winning is putting people on treatment.
Yeah.
South Africa has it has the largest HIV treatment program in the world. We have 3.7 million people on treatment to date. And this is because of the immense support that the public sector and the government have given to people living with HIV to be able to access treatment. Because of this, we have seen things like a decline in mortality from HIV in pregnant women. We have seen huge declines in the number of babies being born with HIV. And we have seen the most wonderful increase in life expectancy for South Africa as a whole.
Dr. Pillay, let's bring you in here. 2016 marks the end of South Africa's National Strategic Plan for HIV, TB and STIs. If you're looking at what the government currently is doing right in the fight against HIV and AIDS, what would you highlight?
Well, if you take the prevention of mother-to-child transmission that Dr. Lehe spoke about, in 2004, we had 70,000 babies being born HIV positive every year. Today, it's less than 6,000. So it's not one, but it's come down dramatically.
Yeah.
So that's the one area that we've made significant progress on. The second is in 2009, we had about 400,000 patients on antiretrovirals. Today, in the public sector, we have 3.5 million and another 200,000 in the private sector. But you can see that the burden of treating patients is in the public sector rather than the private sector.
So just rolling back to the period of denialism when it comes to HIV and AIDS, we had so many people flagging that should more people get on antiretroviral drugs, we might start to see the negative effects of these pills and it might make the situation even worse. What have you found, particularly in the South African scenario, when it comes to that?
Well, the first thing is that, in a short 5 years ago, the average lifespan of South Africans, and it's largely because of the impact of HIV, was about 55, 56 years of age. It's gone up to about 62 years now in a short space of time. And that's largely because large numbers of people, through their own motivations, have gone on to antiretrovirals. The second is that the reason we have 10, 11 million people testing every year is because people see the value of testing and going on treatment Of course, we would like people to go on treatment even earlier, and we would like more people to test, especially men. So we've moved significantly from the period of denialism.
What are the numbers there, just on the testing side, so particularly for men?
On the testing, you know, in 2010, the president launched a national campaign to do testing. And in 15 months, we tested 15 million people. Sadly, more than 50% of the people who tested were women, and about 30% were children, and another 30% were men. So the proportion of men we're testing is not as much as we would like to see.
I know we've got to take a short break, but why is that?
Well, it's largely because men don't typically come to health facilities. If you go to any clinic on any day, you'll see women and babies in clinics. So what we need to do is go out, find the men, and test them in wherever they are, workplaces and communities, etc.
I'd love to get your thoughts on how we can do that better than we're doing currently, but we have to take a short break. And remember, if you'd like to take part, please find us on Facebook and on Twitter. Welcome back. We are taking stock of what's happening with the fight against HIV and AIDS in South Africa, and also very interested in hearing what you have to say on this topic. So please find us on Facebook at Interface on SABC or at Tembisa Magele. So Dr. Lehe, when it comes to some of the ways we can encourage, let's put it very delicately, encourage more men to test, besides going to them in their workspaces, what else are we not doing that we should be doing, in your view, to try and get more people to come out?
The interesting thing about HIV is that it highlights so many problems for the healthcare system that don't always necessarily have something to do with HIV. And this problem with engaging men is not something that is HIV specific. It is something that extends throughout healthcare systems throughout the world. How do we engage men? And we need men's health programs to be able to get men into healthcare and provide them a holistic program of healthcare options to choose from.
But how
one
much
of the ways,
before you continue, how much of that has got to do with the stigma around HIV and AIDS, and also just some of our traditionally held views on illnesses of that nature?
I think certainly there is a role to play of stigma, that it continues. No matter how much we say that treatment is out there and people are living, for sure, stigma is something that people perceive internally. And some men say things like, well, I'll test through my partner, not understanding that results can be discrepant. But one of the great ways that the government has committed to getting men into care is through the male medical circumcision program. The government were very supportive about emerging scientific evidence that male medical circumcision is a way to prevent men from getting HIV. And those programs allow testing of men for HIV.
Has that program been successful?
Yeah, since 2010, we've tested and circumcised 3.3 million men in South Africa. So, it's large numbers of men. We, of course, would like to test more, especially those between 20 and 35, because those are the men that are most vulnerable to acquiring it and then transmitting it to others. Just
getting back to Nonyatyambo on the package that we saw, she was still bemoaning the fact that there's still quite a stigma around HIV and AIDS, and she had to come out and disclose as a result of that. A, is that still commonplace? And B, when it comes to disclosure, what is the status in South Africa right now?
So in 2012, we did a study to try and figure out how much of stigma there is with respect to both HIV and TB. And we found two very interesting things, Tembisa. One is that there's more internalized stigma than externalized stigma.
Explain
what that means is that people feel stigmatized internally in themselves, rather than getting negative comments from other people.
I see.
And secondly, that there was more stigma attached to TB than HIV. Now, that's not very difficult to understand, actually, because, TB is an airborne disease. You don't have to do anything, risky to get it. If you're in a room with somebody who's got TB and who's coughing and not on treatment, there's a good chance you'll get it. Whereas with HIV, in our country, it's mostly sexually transmitted. So if you're not taking part in risky sexual behavior, if you're condomizing, if you know the state of your partner, you're pretty secure in not getting HIV.
Okay. And then on the second aspect of disclosure, Dr. Leher, are we getting issues around people being forced to disclose prematurely before they are ready to disclose? And why is South Africa not criminalizing those people that get into sexual relationships knowing that they are HIV positive and don't disclose to their partners?
I think the landscape of HIV transmission has changed quite a lot in the past few decades. People with HIV after testing are now eligible to get treatment immediately, and treatment has the most wonderful effect of reducing the viral load. And people with suppressed viral load, that means the number of copies of HIV in their blood is undetectable on treatment, cannot pass the virus on to their sexual partners. So criminalizing people for sexual behavior is not something that I'm supportive of. I think people can be responsible. They do want to be responsible. They do want to take treatment and prevent transmission to their partners.
But what is my recourse as somebody who gets into a sexual relationship with an HIV positive person whose viral load is not undetectable, but does not disclose that to me, and I find myself also infected? What's my recourse?
So firstly, let me say, disclosure is completely voluntary. Okay. Nobody should or can be forced to disclose their HIV status. And that's been historic because of the stigma attached to it historically. With respect to people who know they're HIV positive, know that they are not on treatment, and know that they can transmit, there are test cases where that can be something that the person who got the virus from the person that was positive can take them to court for. However, in the health sector, health professionals do not report these kinds of things. Our job is to see patients and treat patients. It's not to act as the police.
I know, but if I do go to court, are there any cases? Is there any precedents where people have won against those partners?
There are cases worldwide, actually.
Okay.
Cases worldwide where, if you know that you are HIV positive and you didn't disclose to your partner. So we would like to encourage partners to disclose, but this is encouraging to disclose, not forcing people to disclose, because it's good for both partners.
All right, when we come back after the break, we'll talk a little bit about the vaccines that are underway and also what happens when you do take those ARVs. Do they make you sick? That's one of the questions we're asking right after this. So much to talk about when it comes to the fight against HIV and AIDS, and it's good news mostly that South Africa is making strides in this regard. And we are in conversation tonight on Interface with Dr. Yogan Pillay, who is the Deputy DG at the Department of Health, and also Dr. Fatima Leher, who is the Director at Hiv Vaccines Research. Now, let's touch a little bit on some of the new vaccines that are coming up. What are some of the breakthrough technologies that you are working on?
The largest amount of breakthroughs are happening right now in prevention science. That means helping people who are HIV negative stay negative and not acquire HIV infection. And these prevention modalities include vaccines, preventative HIV vaccines. And at the moment, there are two types of HIV vaccines that are keeping the science very hot. The first one is the usual active vaccination method, and the second one is called...
What is the usual active vaccination method?
I will explain. The second one is a passive vaccination method. So with an active vaccination method, as you were asking me, this is the same as what you would think of when babies go for their vaccinations when they're born. And that's a shot in the arm. It may be a series of shots. At the moment, we have launched a study that is called HVTN 702. And this study looks at 2 vaccines together in a vaccine regimen given at 5 time points. The vaccines are adapted for the type of HIV that is prevalent in South Africa. The type happens to be called type C. And
Are
this
there
is
any
what is being
side
tried out.
effects to that, though? If I'm HIV negative and I go for these shots, what am I likely to suffer from as a result of
So
that?
we already have tested these vaccines out in previous phase 1 and 2 trials in the last 2 to 3 years. And we did look at side effects and the safety profile. And we're very happy to say that in general, the safety profile has been very, very good indeed. People might feel a little bit sore on the arm after getting an injection, which is normal. But generally, people have been okay. There hasn't been a side effect that has made us alarmed at all. And that is why this study is going to now test the vaccine out in 5,400 people across 15 sites in South Africa. This is research that is being led by South Africans with South African communities that have been pushing so hard for this research to happen.
And if it proves to be, working with that testing of 5,400 people, I think you said, when are we likely to see the mass rollout?
So we will have answers in 5 years' time from the trial. Those answers then have to be submitted to the Medicines Control Council for them to review. They will have a very strict review of this trial. And if everything goes well, we hope after that.
So we're still a couple of
So we're
years
a few
out.
years away, yeah.
But that's encouraging to know that there is all of that good work happening. Dr. Pillay, there's a very prevalent sentiment among people that if you do take these ARVs, even if it is the one pill that we mentioned earlier, they have their own side effects and they're likely to make you sick. How far true is that?
I think we must realize that all medicines have side effects, So, but what we have to do is balance the benefits of the medicines against some of the side effects you might find. So all these drugs, including the antiretrovirals, go through very stringent tests throughout the world. And our Medicines Control Council is the regulatory authority that looks at all of these things to look at whether on balance this is better for you than not taking it. So while it has side effects, and the side effects are, with the new drugs and the new drugs we will be getting in the next few years, the side effects will get even, more limited
less.
and kind of less severe. But it's always what's the benefit against the side effects that we will have to look at.
And the one pill, I know we were talking off air about the one pill being available throughout, but there are still people that will say they're taking more than one pill a day. At what point can you go on to that one pill? Is it even if your CD4 count is low, if your viral load is high, or is there a specific point where you can say now you can take that one pill?
In general, people are being started on the one pill once a day ARV regimen. There can be specific medical reasons why people are started on regimens that include more than one tablet a day. I think in general, most people should be on the one pill once a day regimen. Yeah.
And before we go, Nonja Jambo mentioned that, she got help from private hospitals because the public health system at the time was not very helpful to her. Is that still something that is an issue in South Africa, or have we managed to balance out what gets given in the private space and what is available in public?
No, the good news is that we have over 3,000 facilities in the country, clinics in the country, that are initiating patients on antiretrovirals. So what she was talking about was what was happening in 2004, 2005, 2006. So fast forward to 2016, we have, as Dr. Lahir said, the biggest HIV program in the world and the biggest antiretroviral program in the world. So, we are really very happy that we are able to provide the best drugs most quickly, because now, you don't have to even be eligible with respect to CD4 counts. If you're HIV positive, and you're ready to go on medication, you can go on medication the same day.
Very quickly, one of the biggest challenges, new infections among young people, particularly women and girls. Why is that still so prevalent?
There are two found reasons. One is their social reasons, that women may be
The blessers and the
disempowered.
sugar daddies.
It may in fact be those kinds of reasons. Women may engage in transactional sex work. Women may be vulnerable to people preying on them. But the other reason is also biologic. You know, the vagina is a lining that takes up HIV very, very easily. Okay. And women don't have the advantage of having to go in for male medical circumcision to prevent HIV.
All right.
So that's why a vaccine works.
All right. We're going to be looking out for that vaccine and watching it very closely as the tests develop. But thank you so much to both of you for coming through to talk to us about this. There is a good news story for us as South Africans as we wind down the year. If you've got any thoughts on this one, do find us on Facebook and on Twitter. For us, it's good night.